Hi, welcome to Fridays with Feldman. Today we're going to be discussing cerebral palsy. This is the impetus or the reason, motivation to talking about cerebral palsy now for me is that Dr. Matt Dobbs has joined us down in West Palm Beach from Washington University. And both of us in our previous lives, both Matt Dobbs, Dr. Dobbs in WashU and me in New York City, did quite a bit of cerebral palsy work. Dr. Dobbs worked with Dr. Park, who is one of the experts on rhizotomy, and we'll get to that in a second. And I worked in a very multidisciplinary spasticity unit at NYU. So since coming down to Florida, I've done much less work on cerebral palsy. And so I think now that Dr. Dobbs and I are working together, I think it's an interesting topic. So today I'll talk about some really just ideas, and then perhaps I'll invite Dr. Dobbs in April to talk about and show cases, and we'll show different uses of the things that we're talking about today. So I'm going to invite him, we'll see if he says yes, I'm sure he will. I'll be able to really show you cases and why you would use one versus the other. So, let me skip this.
Nope.
So basically, we'll try to go backwards here for a second.
In the corner, under the Paley logo. That one. There you go.
There you go. We're going backwards. Trying to go backwards. Yeah, I use a computer to go back, but that's not that. Oh, we got a technical difficulty with my little smart board here, but I'm working on it. Okay, we're back. So this slide is backwards, but basically what the point is that you need multiple people to treat cerebral palsy. You need physical therapists and occupational therapists and neurologists and psychologists and nutritionists, and orthopedic surgeons and neurosurgeons and teachers and nurses. And if I forgot somebody, I apologize. But basically the point is that it is a multidisciplinary team to take care of your child or as an adult with cerebral palsy. But the question really becomes is what types of surgeries do orthopedic surgeons do for cerebral palsy? And the first question you ask is what type of cerebral palsy is it? Is it a spasticity? Do we have spastic muscles, which means that on rapid stretch they become very tight? Or are they muscles that just move, like dystonic movements or athetoid movements, which is a movement disorder? So they're treated very, very differently in terms of how we would approach them, whether they're spastic muscles or whether they are muscles that are just, or joints that are just moving. And then we want to know, is the muscle spastic but the joint not contracted? Well, what does that mean? Is the joint going through its full motion eventually, but are we dealing with the fact that the muscle is just tight, or is the joint just stuck where it was? Is it just rigid? And rigidity is another form of cerebral palsy. So you could have dystonic, athetoid, it could be one limb called hemiplegia, it could be two limbs called diplegia, it could be all the limbs called either total body involvement or quadriplegia. So you really have to sort of first narrow it down in what exactly you are treating. Is there growth left? Is there not growth left? Is the tone dynamic, or is it there all the time? I mean, is it there just when you move very quickly, or is that tone always constantly there? Is the joint out of place? Or is it at risk of becoming out of place? And that determines when we talk about surgical correction. And then we talk about which procedure you use for whom, right? Because all of you who are involved in cerebral palsy hear all these different things. Rhizotomy cures all. Back with the bump's the best. I like perks. I like doing little soft tissues. It just depends upon what you have, what age you are, and then how you approach it. So for instance, rhizotomy, usually used below the age of 7, usually used for children who have walking potential, usually utilized when it's just spasticity, not dystonia or athetoid. But the age has been extended. There are some adults who've had rhizotomies for cerebral palsy with some good results. But again, It's a very selective group of people where the spasticity, where that muscle tightness when you move quickly is the main problem, not just weakness, not just rigidity. And that's when you use rhizotomies. So I wrote the fancy term spastic diplegia, no dystonia, and then sometimes we do orthopedic surgeries starting about a year afterwards. Put the hip back in place, maybe some small perks, which we'll talk about in a second. Backlift and pump. When do you use backlift and pump? So I don't want that thing in me, I don't want that. It's really, really good for people who have a lot of spasticity, total body involvement, are not going to benefit from a rhizotomy and just need their tone lowered because oral medication doesn't work nearly as well. But the main goal in cerebral palsy, in someone who has it, is to make people symmetric. It's that asymmetry, one leg shorter, one leg longer, one tone going one way, one going the other way. That's what really causes the problem. So there's different types of, if you have a spastic muscle, what you can do. How do you do releases? How do you make those muscles? So remember, cerebral palsy occurs because of a brain injury, right? So it's not from something else. So we're treating the end sequela. We're treating the muscle, which is the end result of the brain injury. So these perks, or STMLs that people call them, soft tissue muscle lengthenings, or just doing minor things. And I learned perks from someone in New Jersey still working at the Roy Nuzzo, who's terrific and really has evolved the perk into an art form where the perk becomes the treatment of these muscles that need to be elongated. But he's always trying to create symmetry and always talking about how we use those perks. And I know I've done perks for many years, and Dobbs has done perks. It's the easiest way. What it means is you're not really making incisions. You're not making much scarring. And if it's needed, it's great. But if it's not needed and you do it, it's a disaster because the wrong surgery in cerebral palsy is the worst because it makes people weaker. And that's when orthopedic surgeons get bad names. And there's opening lengthenings when you actually do a little bit more of a lengthening, when you only cut in the muscle itself but not the tendon. And there's different things you can do. And then I'm not going to go through all this, just to show you each joint has its own muscles that are involved with it where you may do that. Each knee has a different muscle doing different, whether it's flexion or it's extension, has a different category. Hamstrings, well, don't always lengthen hamstrings if your knees are tight because it's dangerous. Over lengthen is almost an unsolvable problem. Not totally, but pretty difficult. So basically we're very, very careful about how we lengthen the hamstrings. And you've got to be wary that the hip flexors are not tight, that the Achilles is not tight. It's got to be a balance. It's got to be a symmetry. So lengthening hamstrings is, it's a simple operation, just do it. It can be a disaster. It can be a disaster because even the nerve may need to be released because the knee is so tight, it may make your nerve very tight. Ankle contracture solutions, well, it could be many different things and many different muscles. I guess we're doing 2 slides at a time here today. Basically, upper extremities are also, each muscle corresponds to each contracture. Okay, something that I really talk about a lot is hip dislocation. Well, we want to prevent hip dislocations. That's something if you're very young. If it's out already, should you put it back in? And every patient's different. Does it hurt? Does it not hurt? How much function is there of that patient? Are they able to sit well? Are they not able to sit well? Because are they walking? Or are they not walking? So those are the questions you answer. Everybody should try to have it prevented almost never say always, but almost always. But should we reduce it? And then we look at different areas, look at rotation. This is a CAT scan. I must be on fire with my knuckle. Anyway, so basically just showing how this, you can have a dislocated hip and you can put it back in. And again, these are if someone took out these hips when they became so painful. But that's really not the solution in my opinion because they still hurt afterwards. What about scoliosis in cerebral palsy? Also a problem. Also needs to be treated for seated balance. I even recently did a 27-year-old because at any age it can progress and make you unable to sit. So scoliosis, it may be about sitting, maybe about balance. So don't think, and maybe because of the lungs capacity. So it can be many different reasons why scoliosis should be fixed. It can be a progressive deformity even in adulthood. It causes sitting imbalance. It can cause lung and heart problems in cerebral palsy. So I think, again, scoliosis should be evaluated, and bracing is not very useful even in young children with scoliosis. And again, this is looking at someone who's very, very bent and then made straight with that's a unit rod. And again, basically a very, very large curve that I fixed with rods and screws and made it very straight. Well, is percutaneous better? Well, certainly it's theoretical advantages, right? If you hear about percs, it has the advantage of not disrupting the muscle itself. It doesn't make much scarring. We've never done really a study comparing the two, open versus percutaneous. But certainly in my opinion, after doing this now for 26 years, I think it definitely is a very nice option if you're going to lengthen tendons in cerebral palsy. And I won't talk about lever arm disease today, but we can discuss that when we show cases, and some of this is for next time. So I'm just giving you the introduction today, but I will talk about this last slide, which you can't see very well. But basically, these are just the don'ts. Don't miss the opportunity to correct the problem. Don't, let's see if I can actually hit the power.
Just double click that page. On the pages off to the side. In your thumbnails. The little, yeah. Just hit slideshow.
Okay. Lovely problem today. Okay. Anyway, so basically, we talk about the do nots. So don't lengthen a muscle without addressing the muscle that does the other thing. What does that mean? Don't address the hamstring if you're not going to address the quadriceps, because you've got to make sure that it's okay. Otherwise, you're going to over-lengthen something. Don't miss that the child or adult has some athetoid movement disorder, because you're not going to treat it the same way. Don't let a joint dislocate. Don't miss an opportunity to correct a problem where you have to do a salvage problem, like take out a hip, as opposed to preventing it from coming out in the first place. Don't over-lengthen muscles, because you're just going to get weak. Don't create asymmetry. Maybe some people without cerebral palsy can tolerate one leg longer, one leg shorter, or some asymmetry. People with cerebral palsy don't tolerate it as well. And don't immobilize. Don't immobilize so much. I don't use hip spica cast, even if I put a hip back in cerebral palsy, because kids get so tight and they get so dysfunctional, and the bones become weak and they break afterwards. So these are my do nots, which maybe are almost more important than the rest of the talk of what I talk about doing. So I'm going to leave it at that and say that we are going to show cases, and what I hope for the next month while we decide what cases to show is that you ask me what cases you want to see. So you can email me at dfeldman@paleyinstitute.org or on my website, one of the two, and basically ask questions of cases that you want to see us show. And I'm going to ask, Dobbs and I are going to show about 10 cases or 8 to 10 cases of how you would treat something, maybe combined. He would show how he would do it. I would show some of the things where I would do around the hip and around the spine. He would show how he works with the foot. He's an expert on the foot. So I think that would be really helpful if I got some requests for cases that you wanted to see. So I have a little technical problems, but anyway, have a great weekend, everybody. And if there's any questions, I'll take them. But if not, then we will hope to hear from you between now and April. But one second, there's one question which I'll answer now.
Would you use stem cell?
So the question is stem cells. So, this is a really good topic in its own right, and maybe I could talk about it one time, which is the alternative care. I gave this lecture once many years ago, the alternative care for cerebral palsy. Because everybody, when they come and the child's born, they're saying, we want to be fixed. And there's been lots of studies done, and I encourage you to go on to the studies. I think Duke University has done a number of studies on stem cell and cerebral palsy. And I'm not going to answer that question fully, other than saying that there are some really good studies out there utilizing stem cell. But the problem in the United States is that the FDA does not allow a certain number of cells. And so that's why people go out of the country to get stem cells, because the FDA has limited the number of stem cells you can use. So I'm not the world's expert on stem cells, but I certainly can say that yes, I think there's some benefit probably in some regards, but very limited, and we don't know the indications fully yet.
Is it possible for children, adults who have severe contractures that are not responding to treatment be able to opt for a whole extremity transplant?
So the question is can you have a whole extremity transplant if you can't get your leg straight? And the answer is really not. I mean, I don't believe that's possible. An extremity transplant is not useful in this condition because remember, the brain is running it. It's not the contracture. I can eliminate any contracture, so I don't believe that part. The problem is it's the brain not telling the extremity what to do, and that we can't teach someone to do that. So I will leave it at that. And again, I hope to hear from you between now and April, and we'll try to go through some cases and answer some more questions. Have a great day. This ends Fridays with Feldman on February, I believe, 26th, 2021. Take care.